I've been staring at this resignation letter for 2 weeks now, and I still don't know how to explain why I'm leaving. The hospital administrator wants specifics: professional development, better opportunities, family reasons. Pick one. But the truth is, I can't keep working in the ICU after what happened with Thomas Garrett, and I definitely can't write the official incident report they keep asking for, because how the hell do you document something that shouldn't be possible? My name is Sarah Walsh. I've been an ICU nurse at St. Catherine's Medical Centre in Portland for 9 years. Before that, I did 3 years in MedSurg and 2 in the ER. I've seen patients code and come back. I've seen people die despite our best efforts. I've seen families say goodbye to loved ones who were there 1 minute and gone the next. Death in the ICU isn't unusual. It's part of the job. You learn to compartmentalize, to focus on the next patient, to go home and sleep and come back the next day. But what happened with Thomas Garrett? That's different. That's why I requested a transfer to outpatient care. That's why I don't work nights anymore. That's why I've started seeing Dr. Morrison for what she diplomatically calls professional burnout, even though we both know it's more than that. It started on March 8th. Night shift. I was assigned to 6 patients in the cardiac ICU, which is a typical load. Thomas Garrett was in bed 4, a 52-year-old man admitted 3 days earlier with acute myocardial infarction, massive heart attack. He'd coded once in the ambulance, been resuscitated, and had been relatively stable since his emergency cardiac catheterization. His labs from that morning had been concerning. Troponin levels were still elevated, indicating ongoing heart damage. His EKG showed some persistent ST segment changes that Dr. Vargas, our cardiology attending, wasn't happy about. But his vitals had been steady all day. Blood pressure hanging around 110/70, heart rate in the low 80s, oxygen saturation at 94% on 2 liters of nasal cannula. At 11:47 p.m, his monitor alarmed. I was at the nurse's station finishing documentation on another patient when I heard it. The specific tone that means ventricular fibrillation. Your heart recognizes that sound before your brain does, after you've worked in an ICU long enough. I was moving toward his room before I consciously registered what was happening. Thomas was unconscious when I got there, about 15 seconds after the alarm started. The monitor showed V-fib, the chaotic electrical rhythm that means your heart is quivering instead of beating. No pulse, no blood pressure, no respirations. I hit the code button and started chest compressions while calling out for help. The code team arrived within a minute. Dr. Palmer, who was covering the ICU that night, took over as code lead. We shocked Thomas once, twice, 3 times. Pushed epinephrine, continued compressions, shocked again. At 12:03 a.m, Dr. Palmer called it. Time of death, 12:03. We'd worked on him for 16 minutes. Standard postcode protocol. I documented everything, called his wife who was at home sleeping, and started the process of preparing his body for the morgue. That should have been the end of Thomas Garrett's story. At 12:47 a.m, his monitor alarmed again. I was 3 rooms down, hanging an IV antibiotic for another patient, when I heard it. Not the V-fib alarm this time, the regular alarm that goes off when vitals exceed set parameters. I glanced at the central monitoring station where we could see all the patient screens. Bed 4 was showing a heart rate of 89. My first thought was equipment malfunction. Monitors do weird things sometimes. I walked to his room to reset it. Thomas Garrett was sitting up in bed, looking confused. I want to be clear about something. I had personally checked for a pulse at 12:03 a.m. I had felt the absence of a heartbeat under my fingertips. Dr. Palmer had confirmed asystole on the monitor. No electrical activity, no pulse, no respiration. I had personally disconnected his IV lines and removed his breathing tube because he was dead. I had covered his body with a sheet and documented the time of death in his chart. Now he was looking at me and asking what happened. "Thomas?" My voice came out higher than normal. "Can you hear me?" "Yeah, I can hear you." Why does my chest hurt so much? Because we did CPR on you for 16 minutes, I didn't say. Because you died, I hit the call button. I need Dr. Palmer in bed 4, now. My hands were shaking as I checked Thomas's vitals. Heart rate 89, blood pressure 124/78, oxygen saturation 96% on room air, respiratory rate 16, all completely normal, better than normal actually, better than they'd been before he coded. I checked his pupils, equal and reactive. I asked him his name, the date, where he was. He was oriented to all 3. He remembered coming to the hospital with chest pain. He remembered the cardiac cath. He had no memory of coding or dying. Dr. Palmer ran into the room, took one look at Thomas, and went pale. I'd worked with Palmer for 3 years, and I'd never seen that expression on his face. "That's impossible," he said quietly. "I know." Palmer checked Thomas himself. Same findings. He looked at the monitor, then at his watch, then at me. "Sarah, did we miss something during the code? Could he have had a pulse we didn't detect?" No. I was absolutely certain. He was dead. No pulse, no respirations, fixed and dilated pupils. We worked him for 16 minutes and called it. Then how is he sitting here talking to us? I didn't have an answer for that. We ran every test available. EKG, chest X-ray, another round of labs, portable echocardiogram. Everything came back normal. The EKG that had shown persistent ST segment changes earlier that evening now looked perfect. The troponin that had been elevated at 8:47 that morning was now 62, barely above normal. The echo showed normal heart function with an ejection fraction of 55%. It was like he'd never had a heart attack at all. Dr. Vargas came in at 6 a.m. when the cardiology service started their rounds. I watched him review the chart, look at the current labs, examine Thomas, and then read the code documentation from earlier that night. He pulled Dr. Palmer and me into the hallway. "Walk me through exactly what happened," Vargas said. We did, step by step. The V-fib alarm, the code, the resuscitation efforts, calling the time of death, the post-mortem procedures I'd started. "And you're absolutely certain he had no pulse?" Vargas asked me. "Completely certain. I checked carotid and femoral. Dr. Palmer confirmed. He was dead." Vargas was quiet for a long time. Finally, he said, "I've been doing cardiology for 22 years. I've never seen anything like this. People don't spontaneously recover from death 44 minutes after we stop resuscitation efforts." "So what do we do?" Palmer asked. "We monitor him closely. We document everything, and we don't say a word about this to anyone until we understand what happened." But we never did understand what happened. Thomas stayed in the ICU for observation for 5 days. His cardiac markers continued to normalize. His EKGs remained perfect. He had no memory of the code or any near-death experiences. He felt fine, aside from soreness in his chest from the CPR. On March 13th, Dr. Vargas cleared him for discharge. That should have been the end of it. On March 23rd, I was working day shift when I got a call from the ER. They had a patient asking for me specifically. Thomas Garrett had come in complaining of chest pain. When I got down there, he was sitting on a gurney looking sheepish. "I'm sorry to bother you, Sarah, but the pain started about an hour ago, and my wife insisted I come in." They ran the usual tests: EKG, labs, portable chest X-ray. Everything looked normal. The ER doctor examined him, found nothing concerning, and was about to send him home when Thomas's monitor alarmed. V-fib again. The ER team started a code. I stood back and watched. They shocked him, pushed meds, did compressions. 15 minutes of resuscitation efforts at 3:17 p.m., they called it. Time of death, 3:17 p.m. I helped the ER nurse clean the body and prepare for the morgue. The same procedures I'd done 2 weeks earlier. I documented everything in his chart. The ER doctor called Thomas's wife, told her to come to the hospital. At 4:02 p.m., his monitor alarmed again. This time I was standing right there when it happened. I watched Thomas Garrett's eyes open. I watched him take a breath. I watched the monitor show a normal sinus rhythm where there had been a systole 30 seconds earlier. What happened? Thomas asked. The same question he'd asked before. The ER doctor looked like he was going to pass out. The nurse actually backed away from the bed. Thomas, I said carefully, this has happened before. Do you remember? 2 weeks ago in the ICU? I remember being discharged. I felt fine. Then today I had chest pain and... He trailed off, looking around at the shocked faces surrounding him. Did I code again? Yes. Did I die again? Yes. He processed this for a moment. How long was I dead this time? 45 minutes. Thomas was readmitted. This time Dr. Vargas brought in consultants, a neurologist to evaluate for brain damage from the repeated cardiac arrests, an electrophysiologist to look for underlying rhythm disturbances, even a psychiatrist, though I'm not sure what they thought a psychiatrist was going to contribute. Every test came back normal. No brain damage despite 2 prolonged cardiac arrests, no detectable heart rhythm problems, perfect cardiac function. It didn't make medical sense. On March 27th, I was sitting with Thomas during my shift when he asked me the question I'd been dreading. Sarah, am I dying? I mean really dying? Is this some kind of progressive condition? I don't know, I told him honestly. The doctors don't know. All your tests are normal. But I keep dying and coming back. That's not normal. No, it's not. He was quiet for a while. Then he said, the first time, in the ICU, I don't remember anything. But this second time, I remember something. It was like dreaming, but more real. I was somewhere else, somewhere dark, but not scary. And I could hear voices, but they were far away. I wanted to answer, but I couldn't figure out how. How long did it feel like you were there? Maybe a minute? But you said I was dead for 45 minutes. Time perception can be weird during medical crises, I said, though I had no idea if that explained anything. Sarah, what if I don't come back next time? What if the third time is permanent? I didn't have an answer for that either. Thomas was discharged again on March 30th. Dr. Vargas set him up with multiple follow-up appointments and gave him strict instructions to come to the ER immediately if he had any symptoms. His wife stayed with him constantly now, afraid to let him out of her sight. On April 4th, a week after his second death, Thomas coded at home. His wife called 911 immediately. The paramedics arrived within 6 minutes and started resuscitation efforts. They worked on him for 22 minutes in the ambulance and continued in the ER for another 18 minutes. At 2:47 p.m., they called it. Time of death? 2:47 p.m. I wasn't working that day, but Dr. Vargas called me at home. Sarah, Thomas coded again. We worked him for 40 minutes. He didn't come back. How long has it been since you called it? About 10 minutes. Don't prepare the body yet, I said. Wait. Sarah, just wait, please. Vargas agreed to wait an hour, then 2 hours. The morgue called asking when they could pick up the body. His wife was in the family room crying, being comforted by the hospital chaplain. At 5:34 p.m., 2 hours and 47 minutes after they'd called the time of death, Thomas Garrett opened his eyes. Dr. Vargas called me immediately. By the time I got to the hospital, Thomas was sitting up in bed, awake and alert. This time his return had taken longer. Almost 3 hours instead of 45 minutes. Thomas, do you remember what happened? Vargas asked. I remember my chest hurting. I remember falling. Then I was in that dark place again, but this time it was longer, much longer, and the voices were clearer. What were they saying? They were talking about me, about whether I should stay or go. One voice said it wasn't my time. Another voice said I'd already stayed too long. The hair on my arm stood up. Over the next 3 weeks, we monitored Thomas constantly. He coded 4 more times. Each time, the period of death lasted longer. 4 hours, 6 hours, 8 hours, 10 hours. And each time he came back, he reported spending longer in what he called the dark place. He started describing it in more detail. He said there were other people there, people he didn't recognize. He said time moved differently there. He said he could feel himself being pulled in two directions, like something wanted him to stay and something wanted him to return. Dr. Vargas began documenting everything meticulously for a case report. Neurologists flew in from Johns Hopkins and Mayo Clinic to examine Thomas. Their examinations revealed nothing unusual, no explanation for what was happening. His case was discussed at cardiology rounds across the country, shared in urgent emails between specialists. But nobody could explain it. Nobody could figure out why his heart kept stopping. Nobody could explain how he kept coming back from death, or why the intervals kept getting longer. On April 28th, Thomas coded for the 8th time. They worked on him for over an hour before calling the time of death at 3:22 p.m. This time, we all waited. His wife refused to leave his bedside. Dr. Vargas cancelled his other appointments. I sat in the corner of the room, watching the clock. 3 hours passed, then 6, then 12. At 3:22 a.m., exactly 12 hours after his time of death had been called, Thomas opened his eyes. But something was different this time. He looked around the room with an expression I'd never seen before. Not confusion, not relief. Something else. Recognition, maybe. Or resignation. "I almost stayed," he said quietly. "It's peaceful there. Time doesn't work the same way. I could feel myself starting to forget about here, about this life." The voices were stronger this time. One of them knew my name. His wife was crying. Dr. Vargas looked exhausted. "Thomas, we can't keep doing this," Vargas said. "Your heart is stopping spontaneously and we don't know why. The intervals between death and recovery are getting longer. Eventually..." He couldn't finish the sentence. "Eventually I won't come back," Thomas finished for him. "I know. We could. Try to prevent the cardiac arrests. Stronger medications, possibly an implanted defibrillator." "No," Thomas said firmly. "Whatever's happening, I don't think you can stop it. And I'm not sure you should try." I left the hospital that night, feeling like I'd witnessed something beyond medicine. Something that challenged everything I thought I understood about life and death and the line between them. Thomas Garrett coded for the 9th and final time on May 2nd at 2:14 p.m. They worked on him for over 2 hours. They tried everything. Every drug, every intervention, every last-ditch effort we had available. At 4:22 p.m., Dr. Vargas called the time of death. We waited. His wife waited. The whole ICU staff waited. Thomas didn't come back. 6 hours passed. Then 12. Then 24. On May 3rd, his wife made the decision to stop waiting. He told me yesterday that he thought the next time would be permanent. He said he wasn't afraid. He said the dark place wasn't dark anymore. Thomas Garrett was pronounced dead at 4:22 p.m. on May 2nd. His death certificate lists the cause as cardiac arrest of unknown origin. There's no space on the form to note that he died 9 times over the course of 2 months, or that he came back from death 8 times before staying dead on the 9th. 6 months after Thomas died, Dr. Vargas published a case report in the Journal of the American College of Cardiology. It generated intense discussion, but no answers. Several theories were proposed, everything from undetected electrical abnormalities to some kind of hibernation response, but none of them fully explained what we witnessed. I submitted my transfer request the week after Thomas died. I couldn't keep working in the ICU, couldn't keep wondering if every code I responded to might end with the patient opening their eyes hours after we called the time of death. I work in outpatient care now. Routine follow-ups, medication management, patient education. Nobody codes during a routine blood pressure check. Nobody dies and comes back multiple times. But I still think about Thomas Garrett constantly, about the dark place he described, about the voices he heard, about the choice he said he made each time to come back, until finally he chose to stay. And sometimes, late at night when I can't sleep, I wonder if he made the right choice. If maybe that dark place, that peaceful place where time moves differently and voices know your name, maybe that's where we're all supposed to end up eventually. Maybe Thomas just got to see it sooner than most of us. Maybe he got to choose. Medicine is supposed to be about facts, about evidence, about things we can measure and quantify and explain. But Thomas Garrett's case taught me that there are experiences that fall outside those boundaries, events that challenge our understanding of what's medically possible. I still don't know how to explain what happened. I still don't know if I believe the theories about electrical abnormalities or hibernation responses. What I do know is that I watched a man die 8 times and come back 8 times before finally staying dead on the 9th. And I know that changed something fundamental in how I understand death. Dr. Vargas told me once that every doctor has a case that haunts them, a patient they can't stop thinking about even years later. Thomas Garrett is mine. I keep his case file in a locked drawer in my office. Sometimes I take it out and read through the documentation, the code sheets, the lab results, the notes about his progressive recovery times. The last conversation I had with him, where he told me he wasn't afraid anymore, the hospital administration never did get that detailed incident report they wanted. How do you document something that shouldn't be possible? How do you write a formal explanation for a man who died 9 times? You don't. You just carry it with you. You remember, and you hope that maybe Thomas was right, that the dark place really is peaceful, and that when our time comes, we'll understand what he already knew. I'm a nurse. I deal with facts, with protocols, with things I can observe and document. But Thomas Garrett taught me that sometimes medicine touches something beyond the clinical, something we don't have protocols for. I don't work in the ICU anymore. I don't think I ever will again. But I'll never forget the patient who died 9 times. And I'll never stop wondering about that dark place where time moves differently and voices know your name.